Hello, everybody. My name is Gregers. I'm a medical student from Odense, Denmark, and I want to tell you a little bit about the perspectives regarding the post-operative complications following CHI surgery. A quick disclaimer, I'm not a surgeon yet, so my job is to hold a retractor and get yelled at, as I'm sure some of the medical professionals know. And also there will be pictures from surgery, just so you'll be warned. As you can see here. First of all, a quick guide to CHI surgery. At our center, all surgery is performed via a transverse subumbilical incision, cut right here, to achieve the perfect visual, or in our thoughts, a perfect and optimal visual and tactile assessment of the lesion. In focal CHI, as you can see here, well, it's not an easy job, but it's a more favorable job where we can remove the lesion and ideally the patient is cured and there are no further need for surgery. We use intraoperative ultrasound to locate the lesion prior to access of the pancreas. In diffuse CHI, it's another case. As you might know, the optimal course is near total pancreatectomy, which is determined to be between 90 and 98% of the pancreatic tissue removed. However, it can prove difficult to know exactly how much tissue remain, so sometimes the exact number is a bit arbitrary in my experience. And of course, if we remove too much, we get immediate diabetes, and secondly, too little, we might have to access. Again, as you can see over here, it's an enlarged pancreas, and after removal, it looks like this. I'm holding this retractor. So, as you can hear, it's quite extensive surgery. It's akin to the Rolls-Royce of surgery, the Rebels procedure, but not completely similar. So you might expect severe complications. First of all, are any from the Children's Hospital of Philadelphia present? No? That's good. They did the study with 500 pancreatectomies with a small section covering postoperative complications. 3% in the focal cohort of 250 received small bowel obstruction of the small bowel, which is low grade, and they said there were no pancreatic fistulas in all 500 patients. The diffuse population had a complication rate of around 9%. That's really good, but maybe not the closest look ever. So I tried to look through our data using this aim, where it was the short-term postoperative complications for the congenital hyperinsulinism and also insulinomas in pediatric populations, but we won't talk about that today. I went through, after getting permission from the Danish regional board, all of our patients. As you can see here, 74 got pancreatic surgery, and I used a classification model called the Clavin-Dindo and Clavin-Medati classification, which is a classification between 1 and 5, where 1 is a complication without concern, and 5 being immortality. As you might know, you can get several complications in a single patient, so I combined them in what you call CCI, Comprehensive Classification Index, which is a single number between 0 and 100, comprising all of the complications after each surgery. And these are some specific complications for adult pancreatic surgery. Won't talk about those too much, but the fistula is included. You're all, of course, interested in the blood sugar. This is a quick display, 30 days from the last surgery. As you can see, all of the full CHIs were cured. The diffuse is a more mixed picture, and the atypical, which I haven't covered here, is also a case of its own. I'm sure a lot of you are very smart on that. But which complications are the most common, you might ask? Well, the vast majority of complications were infections in the postoperative period. As you can see, up to 30% of patients receive an infection, which I think is a lot, and you know it possibly have troubled a lot of the parents here today. These, of course, aren't strictly related to surgery. As you can see here, a central associated bloodstream infection, which this stands for, is also one of the most common causes. The other thing worth mentioning here is the rate of fistulas. As you might recall, I said that in Philadelphia they don't have any, and we have apparently 11%. which isn't good. My thesis is that we have a strict regimen for looking at the abdominal drain, where pancreatic fluid amylase can be found at 3 days of surgery. We do this with every patient, and in 11% of the cases it's elevated. 7% percentage points is the only thing we see. It lowers itself again. There's no complications. The last 3 are more significant, which requires further intervention. This rate of complications, how impactful are these complications? This is quite a busy slide, but I would like to point to this section right here. If you can take something from me today, is that severe complications, Clavin Medardi 3B and above, occur in 8% of cases, 4% of the focal, and 13% of the diffuse, which we think should be expected. Also, this number here, CCI, between 1 and 100, also shows that a lot of complications occur, but they aren't very severe, and it's possibly because we just thoroughly went through all of our data. So, what can we use this for? The thing I would like for you to know here is that, as I said, 8% of complications are serious, and the clinically relevant fistulae are very rare. As you can see, adults with similar surgery is between 14 and 17%, sometimes up to 35% in other studies. So the children respond very well to quite extensive surgery. And also that traditional radial surgery complications are rare, such as the surgical site infection and post-pancreatectomy acute pancreatitis, also with inflammation of the pancreas after surgery. Well, this isn't the perfect study, as I would wish it was. I had only used respective data, and I was the only person looking through this with help from my supervisors, Henrik, and my surgeons, whenever I was in doubt. Hopefully we've gotten better over the last 14 years. You can see here, it's quite hard to see using ultrasound where the lesion is if you don't know where to look. And also, as mentioned before, there is no lack of internationally agreed upon complications for pediatric pancreatic surgery. So I'll need your help to define them someday. So if any of you can put me in contact with ideally the surgeons and also the patient representatives, so we could do some further research to achieve consensus on both the surgical approach and what complication we should look for after surgery. Thank you very much. Do you have any questions?